So Nancy always tells the story. She's at the board meeting. The way Terry and I got involved with the Graves' Disease Foundation is that I wrote Nancy a letter asking her for her involvement because I saw she had this nice organization. And she was so nice to invite us to Chicago, and that was about 10 years ago, and it's been great ever since, both coming to these meetings and interacting with her and everyone else who comes to these. More recently in Ann Arbor, we started our own little version of this just because of the popularity and trying to offer support to patients. So what I'm going to talk a little bit about today is the surgical rehabilitation of the eye disease. And you can get the sense that each of us have our own little compartment of this disease and our own little specialty, and that's why actually communicating for all of us with each other about you is so important. And so this is my little area of specialty. How many in here actually have any component of the eye disease? Oh, good. Okay. So at least you'll be able to relate, certainly. So the symptoms that you'll feel, and for people who haven't, and we've talked a little bit about this, is the feeling of pressure, especially around and behind the eye. That is actually one of the most common things, and I ask people to point to it, and they point sometimes to their temples, or they just point behind their eyes. Anecdotally, sorting that out with either whether it's due to dryness, and tear duct cauterization is a painless thing in my office, and it absolutely is the most beneficial thing I offer patients. That will get rid of the dryness associated. The other aspect, a way to get rid of pressure and pain, is to sometimes try Flonase, because sometimes that's due to sinuses. That will dramatically reduce it. And then sometimes 10 units of Botox in the temple will take it away about 75% of the time. You don't have to live with the pain and the pressure. That can actually be relieved or certainly improved. The other symptoms that you get, double vision, tearing. We've talked a lot about tearing. Tearing is kind of like smelling an onion. When people with Graves' disease have tearing, that is because you're not producing enough tears. The inflammation attacks the lacrimal gland that makes the tears, and it dries them up. And so it's just like smelling an onion. You're always walking around smelling an onion and having a reflex tearing, desperately trying to provide enough lubrication to your eyes. And that has to be treated with lubrication or preserving the tears that you make, which is often through the cauterization. Irritation, redness, light sensitivity, those are all manifestations of either active inflammation or of the dryness, and very, very treatable. Whoops, sorry. And then the staring look, or the change in facial appearance. We're going to talk a little bit about that today, and it used to be that you had to live with it. And I don't think that you have to live with that. Nancy and I were having a little debate that I think in 80% of the patients who come and see me have eye, and I think that in 80% I have them bring their photos of what they looked like before the disease, and I think in 80% we can make them look as good or better. There are 20% who have severe disease who I can make them look like they did before. But I can make them look relatively normal, that no one would typically know that they had Graves' disease if someone didn't tell them. And that's often our goal. You know, it's kind of branches of a tree. Sometimes the disease is just too severe to reverse everything. But I'm going to show you lots of photos and very little text slides, hoping to give you an idea of what you can expect or you should expect from your local physicians. So we've already heard about the eye being divided into two phases, the active phase and the stable phase. And I'll try not to walk around and keep losing it. So the active phase, I'm not going to spend a lot of time about because typically we don't do a lot of surgery during the active phase. It's more like what Dr. Basernio was talking about, steroids, radiation, new therapies on the horizon. We don't have a great therapy for it. The stable phase is much more amenable to surgery. So what are our goals? I always like to, whenever I have a meeting in my office, or whenever I'm meeting a patient for the first time, one of the first things I ask him is, what do you want out of today? What can we answer or provide for you today? Because people's information will be quite different. Many people come in with huge amounts of knowledge, and they just want it synthesized or reassurance that they're doing the right thing. Other people have just found out that they have this disease and are worried that they're going to go blind. So what are our goals for this meeting? Well, it depends on the disease stage, our goals. what we're going to talk about is not so much the active phase that's been spoken about before, but the stable phase. And our goals are to make sure that the vision either improves or that there's no vision loss, to reduce the double vision, reduce the eye bulging, and improve the eyelid position and appearance. Essentially, what can we do to make you look normal again? This is just a summary, again, of the stage of disease, looking at the active phase, where we try these immunomodulatory therapies, and the stable phase, where we think about surgery. Typically, from the time of onset, it's at least 12, 18 months from the time you start to notice first changes to the time that we're ready to do most of the surgeries that I'm going to talk about today. So we all know about surgery, but let's take a step back. What are the disfigurements of this disease? This disease hits and affects typically women 8 times more frequently, and in their 40s, 50s. Well, I have a wife who's in her 40s, and so I know that women usually in their 40s are pretty concerned about their appearance. And if you have a disease that now is suddenly making your eyes red, making your tearing and your mascara run, making your eyes bulge, making your eyelids retract, giving you bags underneath your eyes, you don't need a quality of life study to tell you that that is not a good thing. In fact, the quality of life studies have actually shown that this disease is about as onerous as being diagnosed with breast cancer. So when your family member doesn't potentially understand, you can start to put it into perspective and educate them that, this is a pretty serious thing. Even though, it looks like a little bit of swelling to you, we're not even counting all the mood changes, everything else that's going on in conjunction with the disease. This is a patient who came in to see us. This is her high school photograph. And as you know, the disease, as you get older, she aged very appropriately, and then Graves' disease hit. And this is, I think, something that many people in the room who've had the eye process can understand, that this is a dramatic transformation. The transformation from high school to adulthood is something that you anticipate. It's a gradual transformation that everyone would expect. The transformation to having Graves' disease is something you don't expect, and it's certainly something that I think that we can reverse. This is another example of just the active inflammation that can be involved and the disease on the top and how we can treat it with anti-inflammatories. But you can see that this comes in a lot of different flavors. And I'm trying to show you the wide variety of flavors in this disease because every one of you should have customized treatment, in my humble opinion. I think that the key to the treatment is customization. So first of all, what's happening behind your eyes? The muscles and the fat both expand. So behind the eyes, you have bony confines here. This is the nose, eyes, and it's like a little ice cream cone. One of those fancy little sugar cones, I think it's called. And if everything expands, everything starts pushing out, and that's where the eye bulging comes from. And then when the muscles start to get big, they start to restrict all the blood flow, which actually has to come to the base of this ice cream cone, and then they make everything around the eye start to swell. In addition, happily, or being very facetious, it also tends to cause scarring. So not only is it swollen, pushing out, but now it doesn't work very well, meaning the eyelids, eye muscles, things. And just a little example of why the muscles expand, start to squeeze the nerve, start to affect the vision in severe cases, but in even less severe cases affect the appearance and the bulging of the eyes. So, as I said, this also turns into scar tissue. So not every appearance of eye prominence or eye bulging is actually due to the eyes bulging. A lot of it is due just to the scarring process, and the scarring process affects the upper eyelids. It causes what's called eyelid retraction, meaning if I held my eyelid way up high, it looks like my eyes are bulging. They're really not. It's just an eyelid scarring that's causing that eyelid to go up higher. So part of the process is not treating this as proptosis and everyone gets an orbital decompression and you move on. Part of this understanding, is this a scarring process? Is it an expanding process where it's pushing the eye forward? What are we going to treat and what are we going to do? And this is just another example of looking down, how people can't close their eyes. They become scarred or tethered. Their eyelids just don't work very well. And, another example of someone who's not able to close their eyes. This is why people get dry. This is why the blinks of people are not normal. And then, obviously, this can also cause double vision, too. So we're going to limit everything to surgery today. And I'm not a surgeon who thinks that I have a hammer and that everything's a nail. I actually think that there are many cases where, and I'm going to show you later on the slides, where I really don't like surgery, and we're doing everything we can to actually prevent things from getting to surgery. But we can do surgery in a very minimally invasive way. It doesn't have to be a surgery that rips your sinuses open. It can be done in an elegant way. It can be done in an outpatient manner. You'll go home the same day, and I'll show you some examples of what we can do. It's done in a staged way, the same way you build a house. First, you start with a foundation, which is the orbital decompression, is making enough room behind the eye that we have room to work with. And then we start building the walls and constructing things around the house, or doing the muscle surgery to realign everything. Then eyelid repositioning, and then making you look normal. So everyone who visits my practice, and I think most of my colleagues, gets a customized surgical plan. First of all is to realize, what do you expect or want? There are some people who when they see a swimming pool, goes jumping in and does a cannonball without even feeling the temperature of the water, versus who puts their toe in and gradually goes in. Who are the cannonballers? Good. Who puts their toe in and then decides and sees how it goes? Okay. Well, there are those types of people when you're thinking about surgery, too. There's some people who say, I'm going big or I'm going home. I want to look like I did before, or don't even bother telling me. Well, I might as well skip the non-surgical options, because they want what they want. And there are other people who said, well, I'm not really sure how this is going to go. So let's do something now. We can always come back and do more later, and let's see how it goes. Those are two very different perspectives that change the dynamic based upon the person of how our conversation is going to go. That's why it has to be customized to the patient's goals and their old photos. So one of the things that Dr. Paserno told you is that we contact patients a couple weeks in advance. We bug them. My assistant calls them. Then the fellow calls them. They're required to bring their old photos, whether it be a high school photo, whatever it is, because I need to know what their face looks like, what they're accustomed to expecting to look like in the mirror. People have very different facial anatomies. What's their bony structure? Oops, jumped ahead. Do they have a small cheekbones? Do they have large cheekbones? Did they always have big, beautiful eyes, or did they always have kind of bedroom sleepy eyes? It makes a big difference, and you can't make someone look. You can make someone look normal, but if they look different, they'll always see themselves differently in the mirror. They have to look like they did before. That's the goal, is that you're trying to reverse things, not to make them look like a new person, a different person. Also, what type of disease do they have? Do they have a fat disease or a muscle disease? Did anyone know that there's two totally different types of Graves' disease, eye disease? One's a fat disease and one's a muscle disease. Anyone know that before? They're two totally different forms. The muscle disease is actually very hard to deal with. The fat disease is very easy to deal with. Fat disease primarily affects young people. The muscle disease primarily affects older people and smokers. Treated very, very differently. The other thing is, what are, in the surgery, the risks? The biggest risk to surgery is, what are the chances of double vision? We can almost always reverse the double vision, but it'll take another surgery. What are the chances of getting double vision? Depending upon the more we do, the higher the chances. So I want to show you lots of photos. And, whenever I show before and after photos, I always kind of feel like I'm trying to sell you a condo or something. No one's trying to sell you anything. I just want to give you an idea of what's available. So, because the internet is populated with scary pictures. Everyone loves to put the scariest picture they have on the internet and freak everyone out. What I want to do is I want to show you a range of what you can expect from your physicians, and you should be expecting. So the first thing is, in our exam, if you have small cheekbones like this gentleman, it's a totally different process. He's always had prominent eyes, and he doesn't have Graves' disease. He also has a lot of rosacea. Totally different treatment. Someone else also has an Asian patient who has relatively small cheekbones, relatively prominent eye, makes a big difference in how we approach the treatment. The types of disease. This is what the types of disease look like. These are almost normal-looking muscles, thin strap-like muscles. The black is all fat in here. All it is fat causing the eyes to bulge forward. They have a huge degree of proptosis, massive, but they almost never have double vision. They're always younger, and they always have a low chance of double vision. I can essentially suck the fat out of this. If the patient wants to do it awake, we can do it awake, or we can do it with them asleep. I mean, they'll have no pain. They'll have monitored anesthesia, but you don't even need general anesthesia. And you can move this eye back in about an hour, and they can go home. I'll show you some before. This patient is tough. They're never going to really get back to where they were, and they're tough. They have variable amounts of proptosis, often not very prominent eyes, but they always have this fibrotic disease. Their eyelids don't blink well. You can just see the dynamic movements of their face aren't quite, around their eyes aren't quite the same, often have double vision, and they also have a high chance of getting vision-threatening disease. This is an example of a woman who has fat-predominant disease. African-American females typically, and primarily affects African-American females versus African-American males are actually a bit different. African-American females primarily have fat-predominant disease and can usually be helped tremendously with this type of surgery. But it's also knowing the demographics. Asian women tend to have muscle-predominant disease and often do very poorly. If people are in the fibrotic stage, again, this is one tip-off that they're going to have that other type of disease. So how can we do a customized, minimally invasive surgery? So what we're going to do is we're going to start from the easiest, well, not quite, because I'll show you non-surgical ways at the end, but the easiest type of surgery and the most minimally invasive to start. That is, first to do a little bit of liposuction of the tissue behind the eyes. Essentially remove some of the fat. Now, the first time I came to this organization, I brought surgical videos with me. Nancy told me, nah, don't bring those back anytime soon. So I'm going to spare you of how we actually do it. But there are no skin incisions, and we go from right inside the eyelids. I can show you if anyone wants to see, but I've decided not to try to impress you with those videos anymore. But what I will do is I'll show you some patients. So this is a woman who has relatively mild disease. You'd say, well, that's a cosmetic disease. Well, she's very bothered by this. She's bothered by the appearance because she's 32 years old. She has relatively small cheeks, fair complexion, and she didn't look like this 2 years ago. She's bothered by this. So this is a perfect type of a decompression for someone like that, where you can just move the globes back, change the eyelid position. Another woman brought in a picture of herself, actually staring. Again, relatively mild disease, but again, big differences. And I'm going to show you very close-up pictures of the eyes. I would bet that if you actually took a conversational distance of about 2 or 3 feet, that you wouldn't be able to see this detail. But these will be close pictures so that you can critique things. Another woman, relatively prominent eyes, had had previous surgery before, meaning that she had previous blepharoplasty. She's only in her 30s, but see how hollow she is around here? That's not a good thing, because oftentimes Graves' disease is mistaken for aging and little bags under the eyes, especially if it's mild. And so you go to the cosmetic surgeon, you get that fat sucked out. And the problem is then that's usually at the beginning of the disease, and then the real problems start afterwards. But a small decompression. This is 1 week after surgery. So you can see that you don't look horrific. You don't look terrible. There are no skin incisions, and you can actually resume your life. So, and this is an African-American female. Again, in African-American females, I will often do a lot of fat decompressions because the recovery is so fast. It can be done under monitored anesthesia or general. Either way, you can do both eyes at the same time, and you can move together. You can move forward pretty quickly. And, a very reasonable result. She'd always had a little bit of hollowness here. And so I think, a tremendous improvement. So what's the next step? So those are the easy ones. That'll get you a little bit, But then there are people who have much bigger problems, meaning that they need some bone removed. You've probably all heard about horror stories of going into the sinuses, and I'm not going to get into any of the technical details, but the fact of the matter is that in 2 hours you can do this surgery, you can do it in a very precise way, you can go home the same day. It doesn't have to be destroying your sinuses or doing many of those cavalier things that were really the mainstay 10 years ago. So this is the only incision pretty much that, and Cesar can back me up on this, I think that I've made in the last 5 years. It's an incision in the eyelid crease, and it's about 1.25 inches long, and you can access everything you need. And the bone I take out is the bone between the eye and the brain, and sometimes I'll take out the medial sinuses, but this is the only skin incision that you need, and it heals beautifully, so you should never see it. And this is an example just before and some of the bone that we remove. So it's just, before there's bone here, and with the advent of technology, there's bone no longer there. Essentially what you're doing is just making more space. And so I don't want to get into the details, but I want to tell you what you can expect from this surgery. The biggest risk of the surgery is that you're going to need at least a week recovery. It feels like you were probably on the bad end of a Mike Tyson punch, because you're going to kind of feel a little sore, especially if you move the eyes. But the biggest risk, at least for a lateral decompression, is about 4% chance of double vision. If you combine that and take a lateral and a medial, if you have more severe disease, depends on the type of disease you have. It can go up to about 15% of having double vision that you never had before and now needing a surgery to correct it. The chances of vision loss, knock on wood, are exceptionally low. When patients ask me, I tell them, well, it's pretty much the same as if you got into a horrific fatal car accident on the ride here, because those are pretty much the same odds. It can happen. It's been known to happen, but will it happen? The vast majority is no, it probably will not. This is a gentleman, and we all love to present our patients who have meant a lot to us. And I know, Alon, that with you, and I think that because we remember our patients. This is a gentleman who I first met at UCLA when I was on staff at UCLA, who had quit his job, who went back and started to live with his mother, and essentially went on welfare because he lost his job. He couldn't see straight, obviously, and he didn't really know where to turn. And so these types of patients start to lose hope. And so one of the things that we had to do was to do a decompression and to realign his eyes. But the real difference was what it made in his life. Because after we were able to do that, and I'll show you the after in just a second, but the important thing is not that he looked better, but the important thing was that it entirely changed his life and what he could do. He could go out now and get a job. He could go out now without having tears running down his eyes all the time. He could actually see without seeing double. And so those are the types of things, especially in severe cases, but also in moderate cases, that are really the gratifying things. And so one of the things we did was to do that. So this can be done. Again, there are no other skin incisions except for the eyelid skin incision. His eyes close and it blink, and there should be no numbness. There's another man who men always get worse disease, who has unilateral disease, and just another example that you can improve these things. Just another example from down below, and that you can move the eyes back. Another woman, and what you can expect. So these things and the surgeries I'm showing you weren't just from decompression. They were also from eyelid lowering. But the idea is that it has to be customized. One size doesn't fit all. You don't offer the same. I don't offer the same surgery to everyone. I don't think that's appropriate. And the technique has to change. So those are the things that if you're going to ask people, that's what the knowledge base that you should have. The next step is typically aligning the muscles, which I do not do, by the way. And so, but it's an extraordinarily important thing of separating the muscle off the eye and then recessing it and allowing things to look for the person to be able to look straight ahead and to move their eyes in all directions without seeing double. Usually we could get everyone to see straight without seeing double. Off to the side sometimes is still tricky. Sometimes they will see a little bit of double. but it makes a huge improvement. I mean, this is, you can imagine walking around and just seeing double all the time, and so these patients do very well. Eyelid repositioning. And this is where you get into not just moving the eyes back, but lowering the eyes. And you only have to lower the eyes. You have to lower the eyelid here, and then account for the skin up here, and then make the contour look like the normal contour of the eyelid and then match each other. It often requires more than one surgery, frankly, just because it's not an easy thing. And people look at your eyes when they're speaking to you, so they can tell a difference of a millimeter in the eyelid height, eyelid contour. It all adds up to a three-dimensional thing you have to reconstruct. But these are just examples of just isolated eyelid lowering. And these are examples that, that your local physicians can achieve. So what are the special cases? And I'm going to end here because I'm going to very soon, because I want to leave ample time for questions and things like that, which I think are always the best. Can you ever look like yourself again or better? Well, again, I think 80% of the time you can. 20% of the time you're going to look better, but you probably will not look quite the same. So realistic expectations are important. So this is a woman who looked better. This is after her decompression surgery. I didn't show you all of her stages, and after her eyelid lowering, and looks better. Her eyes are still prominent, though. Still doesn't exactly look like what she looked like before. And she also has the telltale signs of Graves' disease, meaning that her brows are relatively prominent because the tissue around the brows expands. She's also starting to get some signs of aging, but also the fluid that accumulates in Graves' disease. And when your eyes are prominent, it tends to make the hollows under the eyes look a little worse. So the next stage is then often doing things that are specific for Graves' patients, but to enhance the appearance. And so you can offer mid-facelifting, you can offer skin tightening, and so there are things that you can do that are safe around the eyes. And does she still have hollowness and prominent eyes? Yes. And will she ever say that she looks the same? No. She won't. She'll always look a little bit different. But you can look better. And so the goal is not to see how much better she looks. The goal is to know that if something is frustrating you enough that you want to do something about it, that you can, and you can do it in a safe way. So what are the non-surgical options? I see a lot of patients who have had a lot of surgery already, and I don't want to do any more surgery because there's already too much scarring. And so one of the things we've adopted is using a lot of fillers, especially a Restylane filler, which is a hyaluronic acid filler. And in patients who have a lot of hollowness but still have prominent globes, you can't move their eye back any more safely. And what are we going to do? Well, we start to do camouflage techniques of filling in under their eyes, filling in around the eyes, helping the eyes to close better by altering the eyelid position. And so there's just some examples. This is someone who had an orbital decompression and a reasonable result. They had just a lateral decompression, but still some hollowness around the eyes and still a little bit of a low eyelid position, especially here. This is after an in-office injection of Restylane. It takes about 30 minutes, and you can alter the position of the lower eyelid. And this is actually just after a second layer. And so you can alter the cheek fill, and you can alter the lower eyelid position. They're subtle. They're more subtle effects. But if you're accustomed to looking in the mirror and you want to avoid the risks of surgery, it's a very, very reasonable option for many patients because it allows you to achieve things you can't really achieve very easily, even with surgery, which causes more scarring. The Restylane lasts about a year to 18 months. It has to be repeated about every year and a half. But it's an in-office procedure. Just a few more examples. These patients have not had any surgery. All they've had is they've had some injection of filler to the lower eyelid, cheek area to try to improve A, their appearance, and B, their closure of their eyes. Just another example of a man. A woman who doesn't really have very prominent eyes, but certainly has a prominence in the globes and such. So you can certainly see that we have a lot of surgical options to improve things. And not only can we improve things with filler, there are other ways of putting in implants and bringing out the cheekbones and starting to improve the appearance. And those are all available, but you have to be very careful of what you start to chase here, because some of these surgeries start to get a bit bigger. They start to get a little more complex, and the risks you start to take are a little more. If you have very small cheekbones, like this gentleman here, a tear trough implant and a little bit of a lift of the face can dramatically help the comfort of the eyes and can improve things. But you just have to be very careful when you start to take on these bigger surgeries. So I really do, and patients who have had this disease for a long time, I really do like to start with the non-surgical ways to get a sense as to what your expectations, what their patient's expectations are, and what you can achieve. So I'm going to stop here because hopefully have some questions. If not, we can have an extended break or something else.
While you do that, we're going to try to switch out the computers for the last presentation.
Okay. So thank you. I'll take any questions. Yes.
You let me look in question that you have depression due to muscle.
What's that? Okay. Well, we're done, so I'm going to shut this down anyway, but if it's easier to put it on.
Yeah. So it depends on what you mean by a clear solution. So yeah. So no, the fat tissue was only on the earlier patients who had had much more mild processes. The later patients who I showed that were much more dramatic, those all had bone and sinus decompressions. But again, all done through one incision through the upper eyelid. The fat decompression doesn't require any skin incision. Yeah. And the other point is that I don't want to leave you the impression that we can't do anything if you have expanded muscles. I just want to leave you the impression that it's much harder and it requires a little bit more realistic expectations, you know, and it usually typically requires bone removal and to make a bigger difference. Yes. Yeah. How do you know that you moved into the stable phase? Boy, I wish I could answer that because that's the subject of many of our studies. Pretty much it means that you're not changing. And we make all these measures of your eye position, your double vision, and pretty much when that stops changing and the timing is about what it should be, that usually means you're in the stable phase, and usually we wait a little bit longer than that. Again, it lasts about 12 months of the time things start. Everyone is a little different. Smoking extends the disease quite a bit and is really a confounder, but otherwise, when things stop changing. Over here. Over here. Yeah, chances are, and you know, if you're gonna, if you're just looking at statistics, and if you don't smoke, you smoke. Well, that does change things a bit. That probably cancels out everything I'm going to say. But if you don't smoke, and I can tell my smoking story, but if you don't smoke and you've gotten to this stage, chances are you'll just continue to improve. There could be some bumps in the road. And remember, when your thyroid levels are high, the eyelids retract, and so it makes you look a little buggy. But it doesn't mean that your eyes are bulging. It just means, maybe it just means that your eyelids are retracting. And when your thyroid levels then come back under control, usually the eyelids come down a little bit over about that 6 months, and usually then things trail off. Now, the symptoms that you're having, if they don't go away, you don't have to live with those. You can do various things, you know, supportive measures, some of the things Dr. Kahana talked about, but also some of the things that we do to improve that sensitivity to light, the other aspects. We also want to make sure your eyes are closing and how things are functioning. But with smoking, your expectations are a little different because it's a little more unpredictable. In general, the chances once you have or have reached a stable phase of the disease, the lifetime risk is about 4 to 7% of ever having any reactivation of the eye disease. So it happens about 1 in 20 times of having the eye disease come back, so to speak. Mm-hmm.
And I just wonder if that is an indication of something that
Yeah. So your wife's very observant. Yeah. So when a patient comes to see me, I actually don't. I have someone in there in the room with me because usually while they're telling me their story, because every patient comes in, and you're all patients, you come in with at least 90 seconds of what you're going to tell somebody, and you don't give a damn. You're going to tell them this 90 seconds worth of stuff. So it's easier to ask the patient why, what brings you in, and they really get what's on their mind off. But that's also the fabulous time to observe and do your exam. And the one thing we look at is blink rate, whether the blink is complete, whether one eyelid lags one or another. Often it does in Graves' disease. And so usually if there's a rapid blink, it means you're dry. And you may or may not be feeling it. You may or may not have to treat it. But usually that's the most common reason, is that your eyelids are dry or they're not blinking the whole way.
should I be then, should I seek out an ophthalmologist knowledgeable in Graves' disease at this point?
It could only help. There's very little downside. And the other thing is you can try some artificial tears on your own and see if it improves your comfort. But certainly getting a baseline exam, which you do, hopefully every couple of years, for glasses or just as an eye check, and then letting them know is usually adequate as long as there are no active issues going on.
Does it have to be someone who's thyroid trained, or diabetes trained, or can it be
Yeah.
a general practitioner?
As long as it's an ophthalmologist, and as long as your disease is mild. I always think that it's great for us to see patients once, but I'll usually refer patients back to their local ophthalmologist for continued care if there's nothing active going on.